You're welcome, Dr. Walter.
Okay, can you hear me?
Yes, we can. You're welcome to go ahead.
Okay, good evening, ladies and gentlemen. I'm Dr. Leon Walton. I will be your host for this evening's lecture titled Understanding the First Permanent Molar. Just a few announcements before we get started. Please refrain from using the raised hand, but instead type your comments and questions in the Q&A tab. CPD certificates will be loaded to the HPCSA platform, and you will be able to access all your certificates under your member profile. The event for tonight qualifies for 1 CPD point, and this is also a reminder to please complete the evaluation after the webinar. Okay, on behalf of the South African Society of Orthodontists, as well as South African Dental Association, I would like to introduce our speaker for this evening, Professor Phumzile Hlongwa. Professor Hlongwa is currently the head of Department of Orthodontics at the University of Pretoria, specialist orthodontist holding a Bachelor of Oral Hygiene, Bachelor of Dental Science, Master of Dentistry in Orthodontics, Fellowship of the College of Dentistry in Orthodontics, as well as a PhD. Prof. Hlongwa is an active researcher, teacher, and scholar, well-known and well-regarded in the dental profession. Prof has a broad knowledge of the field of dentistry. She has extensive networks across the dental fraternity, nationally as well as internationally. Prof has a growing publication record with special interest in cleft lip and palate research. She has previous departmental and dental dean experience involving high decision-making capacity. Without further ado, ladies and gentlemen, I'm going to give over to Prof. Hlongwa. We do have a bit of a technical difficulty. So between Prof and myself, we will coordinate the movement of the slides. Prof, over to you.
Good evening, ladies and gentlemen. Thank you, Dr. Walton, for the kind introduction. We can go to the next slide, and I welcome everybody in different SADA platform as you are listening to this presentation, and I'm hopeful that it will give us some lights at the end. We are talking about the permanent first molar, its importance, and why should we take care of it in dentistry? Because we are all dentists, we all know that we have two sets of teeth. This is the primary teeth and the permanent teeth. And we know that these primary teeth, we share them and they exfoliate and being replaced by permanent teeth. However, we have experienced as dentists that we meet adult patients that have primary teeth that never fall off, either because the permanent teeth are missing or the permanent teeth are impacted. This just reminds me of a patient of mine who was 40 years old and had primary canines still in the mouth, primary maxillary canines, and he had come to request some crowns because he was saying that these teeth were small. So when we took a panoramic radiograph, we found that the 1-3 and the 2-3 were impacted. Together with a colleague of mine, the periodontist, we exposed those teeth and we pulled them into the arc gracefully, but it wasn't like a 2-month job. And because he had to take 2 surgeries, first a closed one and then a apical repositioning to bring those canines in line. The patient was happy this Christmas having 2 brand new canines to go and eat some December, as South Africans call it. So we also know that these permanent teeth are supposed to take us to old age, but many people lose it. That is why dentistry will never lose its work, because some people don't take care of their teeth. More especially the tooth we're talking about this evening, the first permanent molar, because it is the first permanent tooth to erupt in the mouth and it should be taken care of. Next slide, Doctor. Looking at the prevalence of caries in the first permanent molar, we realize that the first permanent molar is the most compromised tooth in the oral cavity among children worldwide. Even though there have been improvement in oral health and for many, many decades, this tooth is still susceptible to caries. In South Africa, it is reported that the early childhood caries affects a high number of children below the age of 6. As a result, if the children have caries in their primary dentition, they will have caries also in the permanent dentition. I'm still looking forward to a cohort of some kids that will be preserved and be looked after, not eat sweets, and have teeth that don't have caries, and we can see if they can have all their teeth and not getting caries. But more than 80% of these kids with caries in a survey that was done have not been treated. And the recent prevalence range in South Africa for the DMFT is 1.1 to 2.4, meaning that in the population in South Africa, each individual will have either 1 or 2 teeth that are either decayed, missing because they haven't been extracted due to caries, or they are filled. So the target for a WHO for the DMFT, it's a 0.2. Next slide, please. So if we look at the study that has been done in Africa, looking at the prevalence of dental caries in permanent dentition among 12-year-olds in Africa, you can see that the DMFT ranges from 0 to 0.8, and with South Africa in that region of 0.3 to 0.4, but other countries up there, they have got high DMFT of 0.7 to 0.8. So we still have a lot of work regarding oral health education so that we can reduce the caries prevalence among the individuals in Africa as well as in South Africa. Next slide, please. So why is the first permanent molar important? Firstly, it's because it is an excellent tooth that can record prenatal, perinatal, and postnatal health and disease of an individual. It is also has a specific anatomic location in the dental arch. Its early timing of eruption has an importance to us as dentists, as well as its occlusal morphology that we will look at, as well as the surface area. Looking at the prenatal and the postnatal, I call them 3 Ps. Next slide, please. The first permanent molar, we all know, if we remember our embryology or oral biology, that it calcifies in utero at 9 months. So at birth, then its crowns also are formed. So any complications that occur at the end of the second trimester during pregnancy or 4th year of age, they relate to the mineralization of this tooth. So they can either affect the tooth in the prenatal period due to maternal illnesses and psychological stress, even of the mothers during pregnancy. During perinatal period, cesarean section and other deliveries have been reported to complicate the mineralization of this tooth due to hypoxia in children, as well as postnatal factors may include illnesses in children, including asthma and pneumonia, fever, as well as childhood illnesses. So just looking at the first permanent molar, we can see a lot, whether the child had syphilis when the molar has got mulberry shapes or other diseases. And that sometimes causes stigma in children, because if you say it also for the parents, and you say to the parent, why is this child having a mulberry molar? Did you have any sicknesses? And sicknesses like syphilis, because they cause stigma, they can be a sensitive issue. So we need to handle it with care if we see any abnormalities of this tooth and we relate it to the children and the parent. Next slide, please. So when we look at the calcification of these teeth has been reported by dementia in 1973. This is a very old publication, but it's still relevant to us up to today, which I will encourage you to go and check on it. You can appreciate that the calcification of the cusp, it starts with the maxillary molars before the mandibular molars. But the most important stage that I would like you to look at is stage number E, where the roots are starting to form in the molars. That bifurcation stage is the most important stage that we need to look at in planning whether to extract a Caries first permanent molar in relation to the second permanent molar. Next slide, please. We can move on, Doctor. Thank you. So when we look at the molecular level of this odontogenesis, which we will show in the next slide, it's that a number of genes have been associated with a development or odontogenesis, a formation of the tooth. And you need not to know the names of these genes or even the names of these molecules, but it is interesting to know that a tooth doesn't just form on its own, because molecular biology has shown us that a lot happens at the cellular level for a tooth development. Next slide, Doctor. So the major signaling families, those are like the FGF, the transforming growth factor, the wiggleness-related integration sites, as well as the hedgehog genes. They signal the transcription factors of the member of MSX, PEX, as well as RUNX family, in order for some signaling to take place, whether we are going to form a multi-rooted tooth, a tooth that has cusp, or a tooth that doesn't have cusp. So these transcription factors, they are from the lateral oral epithelium as well as from the medial epithelium. So they regulate the expression of the DLX1, 2, BARX1, and lateral, as well as medial MX1 and 2. As I said, you need not to cram these codes, but it's just interesting to know that at a molecular level, things happen for a tooth to form, so that we have got odontogenic homobox code for tooth identification. Next slide, please. Taking it further, it was interesting to note that research have indicated how different and which of these expressions occur with the molar as compared to the incisor. And with the molar, there's a number of them that need to interact. I'm not going to bore you with all these, but just be cognizant that a tooth doesn't just develop. There are a lot of interaction. Hence, there's a result why we get so many malformations, some of which we can't even explain them on a clinical level. But just to mention that the classification of malformation of molars can be either visualized in terms of the size and the number and the shape, or the surface enamel defects that can happen on a molar. And this can either be genetic, or they can either be congenital or non-congenital due to environmental factors. We know caries specifically, it is due to a diet, a sugary diet. Next slide, please. So when we look at the anatomical location of the permanent first molar, we know that it erupts posterior to the second primary molar. And it sort of established the perimeter of the arc. as a result, maybe you'll remember, and probably you hate it, all of you, when you were in dental school, where you had to measure the arc in orthodontics, and so you can predict the space of the teeth that will erupt in front of the first permanent molar. And the other reason is that in this anatomic location, the first permanent molar doesn't have a primary tooth that exfoliates. So it's sort of like missed by parents. Only dentists know that it is a permanent tooth because it just comes in the midst of the primary teeth, and most parents think it's going to exfoliate. And as a result, it is subjected to early loss, which can cause a lot of issues in the arc, drifting and collapsing of the arc perimeter, as well as over-eruption of the opposing teeth if nothing has been done for the replacement of this first permanent molar. Next slide, please. So when we look at the early timing, and I have already mentioned that it's always mistaken as a primary tooth because it doesn't have a primary predecessor, and therefore it's prone to usual carelessness behavior of parents thinking that it's a primary tooth. And the children also are starting school at this age of 6, so their diet is exposed to sweets, and the tooth end up with pulpitis, and then you do some endodontic treatment, or the tooth is lost and it's extracted. Next slide, please. In terms of its root surface area, it is a multi-rooted tooth, and in the maxilla 3 roots and mandible 2 roots. These root surface areas make it be a very large tooth for a strong grip in the bone. So we orthodontists, we love it because we can use it for anchorage. And even though now anchorage has been made dynamic with so many other things that can be used, but in normal circumstances where you don't need extra anchorage, the first permanent molar serves as a very strong anchorage in orthodontic. Next slide, please. In terms of the occlusal morphology, the tooth has got a larger occlusal table. It allows for chewing, and as the children are growing, they're switching from soft diet into a harder diet, so they need that platform, and because of the large surface area, it's reported that the forces of up to 800 newtons can be resisted by this tooth. So it's enough for biting and chewing hard food. And also the occlusal morphology of this tooth is one of the keys of Andrews of occlusion, which is important also in orthodontics. But however, because this tooth has got deep fissures and deep pits, the cardiogenic bacteria survive and proliferate inside. Therefore, it requires great care to prevent caries. That is why these are just diagrams. You can carry on, doctor, it's okay. These teeth, if they are placed fissure sealants as they come at the age of 6, we can preserve them. We can preserve their mesodistal as well as their width, so that they don't get caries and they can stay in the mouth for a longer time. But we will be speaking on how do we preserve them and what happens if we need to extract. This is just to appreciate that how this tooth look like on an anatomical point of view. And most of the time, we found it being destroyed by environment. Next slide, please. So this is the mandibular molar. It will be very interesting and nice that all the mandibular molars will just follow this illustrated diagram, but we know in practice that it is not the case. Next slide, please. There are a number of etiologies that can have been associated with first permanent molar malformation. infections, like syphilis, as I have mentioned, endocrine dysfunction, malnutrition, systemic disease, craniofacial anomalies, and some of the local factors like trauma can also affect the molar, resulting in its malformation. Some syndromes have also been reported that can affect the molar, just listing a few because we don't have time to list all of them, but I am sure that a number of dentists have seen a patient with orthodontism. We find it most common in our undergraduate clinic where the students are seeing these patients, and whether these patients have got this syndrome of Klinefelter, we are not sure because the syndrome is not just orthodontism only. A syndrome has to have others so that we can call a syndrome, but orthodontism is one of the most common feature that we see in patients that come for treatment at the University of Pretoria. Next slide, please. Therefore, what is the long-term prognosis of a first permanent molar? Every time when you are faced with, you have to ask yourself whether is it good or is it poor, or if you are uncertain, this flow diagram is sort of like can assist in terms of where do you go with the molar? Are you going to extract it or you are going to restore it? So if we look at the good side, we will find that the first permanent molar, it's uncertain, but the second permanent molar it's absent. So you will want to restore this molar because then otherwise the child is not going to be able to eat. Then you will do some restorations, and there are better options in the market now to do some restoration, including minimum invasive restorative materials. But if the molar has got a poor prognosis, then we need to decide whether are we going to do interceptive extraction, if it is a better option. So whether we're doing extraction or not, there are a number of things that we need to look at before we extract the molar. And most of the time, we need to make sure that our choice of extraction, it outweighs the risk for the patient. And for the upper, it doesn't compensate a lot because the upper second permanent molar just falls on drop because of gravity. But the lower second permanent molar, in order for it to replace the first permanent molar, we need to have good timing as to when do we extract and in relation to the development of the second permanent molar. Next slide, please. This is just one of the references I found as I was preparing for this. They advocate the use of the minimal invasive procedure in order you can manage the compromised first permanent molar in children. Most of the time, maybe you just want to keep it a little longer until you can extract it because the second permanent molar is still developing and it hasn't reached the stage where you want it to be in order to extract the first permanent molar. So materials like the glass ionomer materials where you don't need to dig and you can just clean and excavate as long as the child doesn't have pain. And sometimes these caries can be arrested caries, or the tooth is bad, but the child is not complaining of pain. So it really needs proper management and also collaboration between teams, the multidisciplinary team, the orthodontist, the pediatric dentist, and the general dentist in the management of these patients. Next slide, please. So I am challenged by these guidelines from the Royal College of Dental Surgery that they have in regard to the extraction of the first permanent molar, and they update them annually. I think it will be a nice thing to have in South Africa that we can always refer to because of dynamics of our patients. And probably after this presentation, we can collaborate with SADA and SASO to see how can we work together in developing these guidelines in order to help us in preserving the first permanent molar in children. Next slide. So these are scenarios where you have to extract the first permanent molar. You really need to look at the root development of the second permanent molar. When you refer back to the dementia's diagram, this is stage E, where there's bifurcation of the root. It's just beginning. So if you extract at that time, as you can see at the end, there is good contact relationship between the second permanent molar and the premolar. However, if you extract or there's early loss, you can end up with so many scenarios whereby the second permanent molar does not relate well with the premolar, or there is spacing in the premolar, or there could just be poor contact relationship. So those cannot be solved automatically. Obviously, it depends whether the child will have access to orthodontics to upright and to make sure that the contact is good, because we know that poor contact and poor relationship and spacing can be a hindrance and can cause food infection and can result in those teeth being caries. So timing is very, very important as to when do you extract a poor prognosis first permanent molar so that the second permanent molar can erupt and take the position. Next slide, please. In other situations, you may want to extract the first permanent molar because it's caries, because also orthodontics is gonna require extraction where you will want to retract the teeth posteriorly. So that could be an indication. So collaboration again between the general dentist, periodontist, and the orthodontist in terms of can we extract, should we not extract? It's very important, because if extractions are done and the treatment is not initiated with fixed appliances, that space could be lost where we wanted to retract, and we find that we need to extract even more teeth now, the premolars, as in the diagram above. But in the diagram below, planning was done, the molars were extracted because they were bad and the space was used for retraction, and the second permanent molar was aligned using fixed appliances together with in good relationship with the premolars. Slide, please. I just have a few case series to show in terms of some of the challenges that can happen on the first permanent molar. One of the challenges is the MIH, which I'm definitely sure that a number of practitioners do come across these scenarios. So what do you do when the child has got this condition? The tooth can be saved by doing some restorations, or it can be extracted using the timing of the second permanent molar eruption times. So be on the lookout of this. And some of these teeth are very, very sensitive that the kids are being brought by parents because of pain. So extraction in severely affected molars with MIH is an indication, but it's not just like a willy-nilly. You need to make a decision that is informed, that is weighing the risk of the extraction as well. Another scenario, this particular patient came in with caries of the first permanent molar and the early loss. But surprisingly, that the main complaint was, I can't bite with my front teeth. So the parents were not even aware that the first permanent molar are caries, and even the one that was lost, they thought it was a primary tooth, it will still come. So in this scenario, we can see that we are already late. If we look at the upper maxillary right first permanent molar, the 1/6. If we extract that 1/6, the 1/7 is not going to just fall into the space and close the space of the 1/6. It will really need some traction and some orthodontic alignment in order to get that. Together with the missing 3/6 as well, the 3/7 is just erupting and floating there. There is a space. So this patient definitely will need fixed orthodontic treatment so that teeth can be aligned and be close together. And we can appreciate that even the wisdom teeth are going to be impacted because there is no space in the mouth even after the extraction of the loss of the first permanent molar. In some situations, a patient will come and you can see that the E's roots are not resolving. If you leave it like that, it will cause impaction of the second premolars. So you might need to do some interceptive orthodontic treatment and put a fixed lingual arch and then extract those E's because the second premolars are erupting either lingually or away from resolving the roots. Then if you do extract and you create a way, then the second premolars will then erupt in the right place and the 6's will not drift. So provided the caries are not there. Next slide. This patient, you can see, came with very curious 6's, 1/6, 4/6, 3, even the 3/6. But even the primary molars were curious. So the treatment of choice here, even though we are late also, if we look at the development of the 7, is extraction of the first permanent molar, because there is no way you can leave it. It's just badly curious. If you want to do endodontic treatment here on this child, it's one of the options, but because they have poor oral hygiene, the treatment of choice for this child was extraction of all the 6's. The one side was done, the extraction, and the child still need follow-up for the extraction of the other teeth. Because the child was above the age of 6, the extraction couldn't be done in theater in the government setting. I think in private sector, when the child have the fees or the means, the parents to pay, this extraction could have been done under one setting so that the child is not subjected to numerous injections. But looking at the current situation, because they are being treated in a government setting, one side is done at a time, and sometimes these children never come back. They will come back with a swelling and with an infection, and it is sad to see that. One of the other things that can happen to the first permanent molar is a delayed eruption. This child consulted us at the age of 6.5 years. None of the permanent first molars were in the mouth. And fortunately, they just come for a routine checkup. I don't know, maybe this parent is just aware of oral health checkups. And the child was being monitored because we were suspecting that there could be ectopic eruption, especially in the mandibular arch. And in the follow-up treatment, we realized that the eruption was coming okay, but there is a severe space shortage in this child, where we will need then to maintain the space and maintain the leeway to prevent future challenges and problems that may come requiring orthodontic treatment. So here is the child now after a 1.5 years follow-up, and the lower mandibular first permanent molar had erupted in the mouth. Now we can prepare to give this child a fixed lingual arch so that we have planned a extraction of the primary teeth to preserve the space and make sure that this crowding is maintained, is minimized. And so when the treatment comes, it's not like a long orthodontic treatment. So this particular patient came consulting with being referred by the teacher. So there are teachers out there in schools who look after the kids and even see that they have malocclusion. The teacher saw that the child had a class 3 and just say, go and see a dentist, you are not biting, okay. But when we examined this child, we realized that even at the age of 9.5, the upper first permanent molars have not erupted. They are ectopic and they are just like sitting under the ears. So the treatment for this child was to extract the ears so that these first permanent molars in the maxilla can erupt. And at this stage, we are trying to give the child a face mask to see if they will comply with early treatment now that they have come. But there are pros and cons. I mean, different schools of thought: wait until she's grown or intercept at an early age. The jury is out there, but because they have come, then we are starting the treatment like that. Next slide. Five-year-old African female, main complaint, back teeth are painful. So when we examined, we saw that he has Caries ease, but ectopic eruption also of the first permanent molars. In this instance, it's easy because you can extract the ease and put a Nance holding arch on an FLA, a fixed lingual arch. But if the ears are not curious, there are ways in which you can treat ectopic eruption of the first permanent molar by just putting a separating elastic. It just separates and opens the space for the molar to come, or a copper wire being inserted between the E and the 6. It just disimpacts the 6 and you get the 6 back into the mouth. This particular case presented with early loss of upper ears. We know there will be drifting of the upper first permanent molars and closing the space to cause impaction of the premolars. So this patient needs interceptive orthodontics, which can be administered by general dentists, putting a Nance holding arch as well as a fixed lingual arch for this patient. and continuous follow-up, because then you have to monitor the eruption and the transitional dentition before the patient. You can decide whether will they need fixed orthodontic treatment. It's a long-time treatment that can happen to this child until all the permanent teeth have erupted. If they come at the age of 6, so it means you've got 4 to 5 years of follow-up with this child, maybe every 6 months or every 3 months, depending on the general dentist and the availability of the child and the parents as well. But we have seen these follow-ups being done by our undergraduate students, and it yields good results. So the E's have been extracted now on this particular X-ray, and measurements have been taken to construct a space maintainer for the maxilla. This particular patient at the age of 10.5 years came, and their main complaint was skewed teeth because of the upper teeth, the mandibular teeth, they were biting into the palate. You can see accentuated curve of speech. They were not bothered about the caries, but when they come, when we examine them, we saw that the first permanent molar are grossly carious. So you can see that the 4-6 is almost finished, as well as the 2-6. And the parents didn't see anything wrong with it. And this child was not complaining that it's painful, but these are just like some of the severe caries teeth that can happen. So it just shows that even with the DMFT of 1.1, it's likely that those teeth in those DMFT are molars, because you can see even in this patient, all two of the permanent molars are grossly carious. The other one has a restoration. So it's some of the things that we need to look at out there on how do we preserve these teeth so that we can preserve the occlusion. There are consequences of early extraction of compromised first permanent molars that can happen. And if you like to read this systematic review, you will realize that the ideal time for the first permanent molar extraction is important. And you look at the second permanent molar when it's bifurcated, as we have discussed, it's stage number E. And also, is it there? You outweigh the benefits as well as the risk of extracting. But this systematic review found that the outcomes, they are so variability. Therefore, they are recommending a prospective study that can come with a valid answer to our question. So we still do not have an answer that can ask whether is it good to extract or is not good to extract. First permanent molar, if they are lost also, they can have they can impact the treatment as well as impact the space closure. In this particular review, they realized that if they take children that have lost first permanent molar to close the space compared to the ones that have lost first permanent molar, the orthodontic treatment time was double. It took 44 months to close the space as compared to those that didn't have the molars lost, which took about 22 months to close the space. So there are effects even on treatment that can affect us if the first permanent molar is lost before time. just a summary of what I've already said. 2 groups, 19 first permanent molar that were lost, 24 were controlled, and the treatment time was 44 months for those with the first permanent molar lost and 22 months for those with. Then the conclusion is that increased orthodontic treatment time if the first permanent molar is lost before time to close the space. Therefore, in conclusion about this first permanent molar, it is important for us that we know the importance of the first permanent molar in occlusion, and we know that if it is compromised, it can negatively impact on the quality of life of the child because they won't be able to chew, they will be in pain, and also early diagnosis and treatment planning is important, especially that we must have a multidisciplinary team working together for the best outcome of these children. It is also important that we continuously conduct oral health education, encourage brushing and flossing, and regular dental checkups so that these problems can be intercepted early. It is said when the child comes and it's late and there is nothing you can do but to extract the tooth. And lastly, I would like to advocate that let us save the first permanent molar. Thank you very much, Dr. Walton. I think this is my last slide. These are some of the references I have used in preparing for this presentation. And I appreciate your advancing of my slides. It feels like I'm using those transparencies, say next slide, but technology sometimes fails us. Thank you very much for all the listeners, and thank you to SADA and SASO for the opportunity to present this, and I hope that it's going to start a conversation around this first permanent molar. Thank you, Doctor.
Thank you so much, Prof, for this very enlightening lecture. There are a few questions that has come up in the Q&A section. I'm going to start by reading the first one. Do you think that epigenetic factors play a part in the morphology and anatomy of the first permanent molar in the pre-agricultural and industrial revolution phases in human history and development? That is the first part of the question. And then the second part of the question, what are your predictions for tooth morphology and anatomy of the first permanent molar with modern era epigenetic influences for the next 50 years, starting now with the Big Mac and digital era of AI?
Sure, Doc, that's a mouthful, that question.
I'm happy you have to answer that.
I think it needs a PhD thesis to answer the question. I think the first question is true that the change of diet, because there are environmental factors that affect, but genetic plays a role as well. So in the formation, basically, because the first permanent molar calcify in utero, it means whatever the mother eats is going to play a role into a transmission in the formation of the cusp. I read an article that says how even these mulberry molars are formed is that because syphilis is, for example, it's an infectious disease. So these spirochetes, they penetrate the placenta and they go into the epithelium where the crown is still forming, and that's how then they change the form. Instead of the crowns forming better, it ends up being like a mulberry. So epigenetic, it's outside, but genetic, it's inside. So once the tooth is formed, it's formed inside. So outside is exposed to some of the insults that can cause us not to strive. But the second question, I do not have an answer in 50 years. I wish I do. And I wish I will still be living in that next 50 years so that I can also testify to this question. I have passed the age of 50. And I'm looking forward to this answer as well.
Okay, Prof. Thank you so much. Then Dr. Vishani Soni, must be one of your students. She's got two questions as well. Would you still recommend Bolton's analysis and Schwarzkopf's analysis for model arch analysis? That is the first question. And then the second one, in terms of molar assessment and accuracy of X-rays, would you recommend the new digital cephalometric analysis as an accurate representation of the first molar position? And is the digital ceph as accurate as the hand-drawn ceph analysis? And she thanked you for a great presentation as well.
Bolton analysis is an analysis that we still use in orthodontics. It is just an analysis that checks if the teeth are interdigitating. We still advocate it, our students still use it. I know that now you can even calculate Bolton analysis digitally with the digital scanning. So it's just an analysis, it's a mathematical formula. So it doesn't matter whether you do it by hand or you do it digitally. It doesn't help as to whether the molar is early lost or is not lost, because once the molar is lost, you can't do full Bolton. Already we advocate that there is a Bolton discrepancy. In terms of digital SF and manual tracing, we are going digital. We are in the fourth industrial revolution. There is accuracy in digital tracing. However, you need to know your landmarks, because I always tell my students, garbage in, garbage out. If you put your landmarks, anatomical landmarks wrong, then the digital tracing is going to be wrong. So back to basics, we know our landmarks, then we can do the digital. And most of the things, even at the University of Pretoria, we are trying to be digital, but we know the cost of digitalizing everything, especially in training institution, because it's license-based. Digital, yes, I support it, but we need to know the basics.
Okay. Thank you again, Prof. If the audience have any other questions, please post it in the Q&A. Prof, at this point in time, I don't have any more questions listed here. Do you perhaps have a parting message before we have a look at, oh, okay. I see, we've got another question. Here's one, Prof. What is the incidence of impaction of the first permanent molar? Please also give treatment options. Thank you for a lovely presentation, Prof. That is from Dr. Sagathavan. I hope I pronounced it correctly.
I have checked the literature. I couldn't find an incidence of impaction of the first permanent molar. Being the first tooth that erupts, it's not competing with space with any other teeth, except if there are other aberrations like infections or diseases or pathology, or it's ectopic. So if it is impacted, then it will need probably to be extracted, or now we have what we call auto-transplantation. It just depends on the timing. If we can see it early as the roots are bifurcating and the mouth is healthy and there is no infection, I think the tooth can be assisted to come into the oral cavity through auto-transplantation and be supported that it can grow. But you have to look also if the 7 is going to erupt and this tooth is ankylosed because it hasn't erupted, there could be some causes. It just could probably need extraction. I think it is a question that probably we could go and research, but I tried even preparing for this presentation to check if there is any incident of impaction of permanent first molar. They are not even counted in the incident of impaction. We know that it mostly the wisdom teeth, and then followed by the canines, and then followed by the premolars, and then even the central incisors have got a high incident of impaction as compared to the first permanent molar.
Thank you, Prof. Then the next one, Prof, what is your opinion on early interceptive orthodontics with Myobrace? I think it says here in terms of combat space problems before the eruption of the first permanent molar. Myobrace, early interceptive orthodontics.
I don't have experience with Myobrace, but how is Myobrace going to assist us with the eruption of the first permanent molar? I don't understand the question. But interceptive orthodontics can be done to patients according to the indication. If your patient you have examined and you think that they will benefit from Myobrace for certain reasons, do it. But it's not so that the first permanent molar can erupt. So we cannot say that Myobrace will assist the eruption of the first permanent molar. Myobrace has its own indications and its patients that can be selected to be used for it. But I don't have much experience with Myobrace.
Then there's a question, Prof. In the case where first permanent molars can be saved with endo, but don't have a very long prognosis, would it be better to do the fixed ortho with that endo tooth in the mouth and then redo the ortho once the first permanent molars have been lost? Or is it better to extract from the start and then do the ortho?
I think we have explored the ways on which, when will we extract the first permanent molar. It depends on the development of the second permanent molar. So if you can weigh the risk of whether would you want to do endo or to extract. Obviously, endo will bring money into the pocket, but does it outweigh the risk? So if orthodontic treatment needs to be done and the first permanent molar is badly curious and it needs endo, orthodontics can move endodontic treated teeth. So it's just a matter of doing a proper diagnosis and planning as to, do I extract the tooth now, do ortho, or do I do endo, extract the tooth later and close the space later? Depend on planning. Also, this planning also is determined by at what stage or age of development of teeth does the patient consult you? Because the patient can consult you at a later stage where now you're supposed to just do whatever you can do. But if you look at the dental age of the patient and the stage of development, your planning starts around it.
Thank you so much, Prof. Can a well-controlled pregnant type 1 diabetics baby be affected by the fact that the mom has diabetes?
Can you rephrase the question again?
It says, Prof, can a well-controlled pregnant type 1 diabetics baby be affected by the fact that the mom has diabetes? I would assume.
Or maybe was it affected by the mother who has diabetes?
I
wish I was a gynecologist, but anyway, I didn't invite the gynae into this. But, we know that diabetes in pregnancy is not a good indication for the fetus. So even gynaes, they really look after these mothers who are diabetic because they want it to be controlled, because diabetes can be genetic transferred. So, but we know also that diabetes affect the first permanent molar morphology. So whether the child got it from the mother, or whether it developed after the child was born, it is important just to know what kind of diabetes they have. But the most common in children is the type 1. Type 2 is more common in adults. So incidentally, we are just writing a paper on the effect of diabetes mellitus on orthodontic treatment and periodontology, because we know that once patients have got diabetes, there's poor oral hygiene and there's poor healing as well. And there are so many things that we need to know about systemic diseases that affects our day-to-day treatment of patients in the oral cavity, because we're not just treating the teeth, we're treating the human being, and there is connection in these things. I hope I have answered. I tried, but yeah, I didn't understand the question well.
Yes, Prof. Then there's a question where it states, in a case where the first primary molar is in place, but radiographically there is a transposition of first permanent molar and premolar, what can the healthcare provider do in an instance like that? What would your advice be for transpose test?
Transposition is common, but I have not seen transposition of a premolar and a first permanent molar in my entire 20-odd years in ortho. I've seen transposition of canines and incisors and premolars, but if it happens, you have to treat the case as it is. If the tooth is in the mouth and it's in occlusion, as a general dentist, you know what to do if it is in proper contact. There's no need to extract the first permanent molar due to just transposition. But if it is just an isolated case, and this case doesn't need orthodontic treatment or doesn't need extractions for orthodontic treatment, and the tooth are not caries, patients function with those teeth. I have a patient we are treating right now at the dental school. She had 2 central incisors and a lateral incisor. We were contemplating of extracting this other tooth, but we just say, let's level and align this child because she was thumb sucking, and let's see what's going to happen. She has 5 incisors in the front and she's happy. And the mom says, no, we're not removing any teeth. So extra teeth, transposition teeth doesn't warrant extraction, not unless they are disturbing occlusion. So we just need to make sure that we do proper diagnosis and treatment planning, and we plan around the scenario.
Thank you so much, Prof. Then there's another comment from Dr. I think this is Dr. Potgieter. I wanted to thank you for a lovely lecture. It doesn't appear as if we have any other questions, Prof. We just wanted to thank you for your time and effort into putting this lecture together and coming out this evening and presenting it to the audience. Thoroughly enjoyed learning from you. Looking forward to hearing from you again or listening to one of your lectures in future again.
Thank you very much, Doctor. Thank you for saving the situation. Yeah, ESCOM and load shedding, but yeah, we are going to vote. So maybe after voting, we will be better. I'm not campaigning for any party, but thank you so much to SADA and SASO for the opportunity, and to all the listeners out there. Let's have this conversation and see how can we save the first permanent molar. Thank you, Doctor.
Thank you. Just one last reminder to please complete the evaluation after the webinar. Thank you so much, everyone. Have a lovely evening.
Thank you, everybody. Good night.